Hey everyone, welcome back to PS Platypus. Today we're going to be having a look at the eyes in terms of anatomy. So that's the orbit and the extraocular eye muscles, and a bit of clinical context behind all of that, and also a bit of physiology. So in terms of the contents of these slides, we're going to be covering quite a bit of information, and that's all covered within this slide over here. So we're going to be talking about the orbit's anatomy, boundaries, contents, openings, and then the clinical context of blowout fractures, the extraocular eye muscle, which is probably the most important thing I want you to take away from the slide set, especially the clinical sort of component of that, which is H testing and nerve palsies of the extraocular eye muscles. Very important to understand, especially for the exams. So keep that in mind. And then we have the innervation of the eye, another minor point there, and the annulus of Zinn. The visual pathway, again, another very important point to cover, and the visual pathway lesions. Also keep an eye out for that. And then some miscellaneous topics for anatomy. So the eyelids, the eyeballs, surface anatomy, clinically talking about glaucoma, myopia, hyperopia, presbyopia, astigmatism, also known as short-sightedness and long-sightedness. We'll come to what that means later on. What we won't be covering in this slide set, though, is fundoscopy, which is more of a clinical skills thing, which we'll have a separate video on later. And also the cranial nerve nuclei, because we're going to have an entire video dedicated to that in neurology, and I'll be taking you through that at a later stage as well. But you'll learn about how the cranial nerve nuclei control things like movements of the eye muscles, and how they originate in the brain, and how different pathologies like strokes might affect the nuclei and their function. So with that being said, let's get started. Let's start off with the orbit and the anatomy of the orbit. So we're going to start off by having a look at the boundaries of the orbit. And when it comes to the boundaries, it first helps to understand the major bones that form the skull, where they're located and what they're called. Now, three major bones to keep in mind that form the orbital rim, or the outside portion of it, is the frontal bone. So this yellow bone over here in the diagram is also this red bone over here, which is that big piece of bone that forms the forehead. And then we have the zygomatic bone, which is this blue piece of bone in the diagram, but also the orange piece of bone up in this diagram, which is going to form that medial aspect of the rim. And then finally, the maxillary bone, which is this pink/purple bone in both diagrams, and it connects to the top row of teeth. So it's also important to keep in mind when it comes to the orbital rim. So now you've already learned three bones, and you know exactly what makes the orbital rim, which is already a great start. But now we have to learn about the inner contents or the inner walls of the orbit, which can get a bit more complicated because more bones involved here as you go deeper into the orbit. So we'll start off in familiar territory with the medial wall and start off anteriorly with stuff that we already know and work our way backwards. So if we look at the medial wall of the orbit, it makes sense that the most anterior structure in the medial wall of the orbit is going to be that bone, which is going to connect to the top row of teeth. In other words, the maxillary bone. Then as we go further back, we get the lacrimal bone, which is going to be situated close to the lacrimal duct that drains tears from the eye. And then we have the orbital plate of the ethmoid bone, a tiny sliver of bone at the back there. And then the sphenoid bone's body is also going to be there. And you can see the optic canal coming out of that as well, which is going to have the optic nerve and the ophthalmic artery there. We'll not talk about that just yet. We'll have that on the next slide. But you can see the four bones there, anterior to posterior, the maxillar bone, or the maxillary bone, the lacrimal bone, the ethmoid bone, and the sphenoid body. The four bones on the medial wall. Easy enough, right? And then we come to the roof of the orbit, which is two very easy bones to understand. The first one is going to be that big forehead bone, in other words, the frontal bone, and the orbital plate is the portion of it which we regard as being that superior roof. The other bone is, again, the sphenoid bone. So you can see the sphenoid bone actually pops up quite a lot when it comes to the walls, and we'll talk about why that's the case as well. But in this case, it's going to be the lesser wing of the sphenoid bone, which you can see right there on the diagram. We'll talk about that in a second. The lateral wall of the orbit is formed by two of our familiar bones again. It's going to be the maxillary bone and the frontal bone. So they form sort of the lateral aspect of the orbit. But then as you go deeper in, you can see that, again, the sphenoid bone once again makes an appearance with the greater wing of the sphenoid bone, this time forming the lateral wall of the orbit. We'll talk about how the wings and the body actually come into play in the orbit in a bit as well. After we talk about the floor of the orbit. So the floor of the orbit is again formed by two of our familiar bones, being the maxillary bone and, the maxillary bone here and the zygomatic bone here. They're going to form the floor inside the orbit. And then a tiny sliver of bone, which is the palatine bone, which makes sense to sit sort of more inferiorly where the palate is. And that's going to form the floor of the orbit. So that's all of the orbit anatomy complete and done. Now I'll talk about how the sphenoid makes such an appearance three times with a medial roof and lateral wall of the orbits. So if you have a look at the sphenoid bone, this is the sphenoid bone itself. Up here is the anterior part, which is going to be the orbit and the eyes, and then down here is everything posterior to the sphenoid. Now, if you have a look at the anatomy again, the body of the sphenoid makes sense for it to make the medial wall because it's the most medial component lying in the center or the midline. And so you can see how it might form the medial wall of the orbit, or part of it would. And then the lesser wing is a structure that lies laterally to the body, but also above the greater wing, which is why it forms the roof of the orbit, whereas the greater wing comes out more laterally and forms the lateral wall of the orbit below the sphenoid bone's lesser wing. So I hope that all makes sense. We're going to now talk about the contents of the orbit and the openings of the orbital cavity. There's three openings here, but I say two because two of them are actually continuous. So the optic canal is its own opening here, right? Whereas the superior orbital fissure and an inferior orbital fissure are actually a continuous opening. So even if you go back here, you can see how they're one continuous slit, but we consider them to be separate openings because they're quite far apart and contain different structures within them. So starting off with the optic canal, that is situated, first of all, within the sphenoid's lesser wing. It comes out through there and a little sort of opening inside it. And it contains the optic nerve or cranial nerve 2 and the ophthalmic artery, which is going to go to the eye and supply it, and the retina. Superior orbital fissure, on the other hand, contains cranial nerves 3, 4, 6, and V1, and the superior ophthalmic vein. So this is again easy enough to understand because if you think of all the extraocular eye muscles, which we'll come to in a second, they're supplied by cranial nerves 3, oculomotor, 4, trochlear, and 6, abducens. So those are the 3 extraocular eye muscles, the nerves that supply them. So the 3 nerves that supply the extraocular eye muscles and how they all come out of superior orbital fissure. V1 is the ophthalmic division of the trigeminal nerve, which comes out through here, which again makes sense for it to come out this superiorly. And then the superior ophthalmic vein is also here as well. The inferior orbital fissure contains the counterpart of the superior ophthalmic vein, which is the inferior ophthalmic vein. It also contains the maxillary branch of the cranial nerve 5 or trigeminal nerve, which is called the zygomatic branch. And it also contains some sympathetic nerves that we're going to be talking about later on in the context of Horner syndrome as well. But it's important to just know that they exist here for the moment. And you can have a look at the diagram on the right here and see exactly how those structures emerge and come out through there. But really the only important thing to understand is that you have these 3 openings and they contain the contents that are described in the table there. And then clinically, we talk about the blowout fracture. So this was my LO when I was doing anatomy last year. And in terms of the cause of blowout fractures, it's usually due to trauma to the central orbit. And there's 2 ways that can be caused. So that could be a punch, for example, or it could be, for example, a baseball. And essentially, what happens is the impacting object is usually larger than the eye socket itself. So what that means is, rather than going through the eye socket and hitting the eye and then just smashing it or piercing through it, it actually gets stopped by the orbital rim. So it doesn't able to go all the way and squeeze the eye. It gets stopped from doing that. Now, if you're going to push the eye, it's going to get retropulsed, or the contents of the orbit, so the eye and the muscles will be pushed backwards. And because of that, the intraorbital pressure rises because you're compressing all the contents, squeezing it backwards, and causing the pressure inside the eye and the surroundings to rise. Now, if you have pressure rising, it's going to put more of a force on the things surrounding it. And because of the way that the orbit is structured and the orbital walls are structured, the weakest wall in this case is actually the inferior wall. And so it will actually tend to fracture and cave. So the inferior wall breaks, and that causes the structure or the inferior rectus muscle to go downwards. And sometimes it might just go downwards and then eventually it'll heal and go back to where it was. But in children where the bones are still developing and are quite flexible, it can actually have that bone fragment trapdoor it, or actually squeeze onto the muscle. And therefore the inferior rectus is no longer able to function. And you have a situation where the person can't look down anymore because the muscle that's supposed to grab onto the eyeball and pull it down is squeezed inside this bony fragment. So we'll come to the muscles themselves later on, but I hope that sort of explains to you how a blowout fracture works and why we get presenting symptoms of orbital swelling, because if you punch that area, you're going to get edema, swelling, inflammation of the area, and tenderness because of that inflammation irritating the nerves nearby, and diplopia, which is double vision as a result of the impaired extraocular eye muscles. So that, for example, let's say you want to look down at something like the keyboard on your laptop, maybe the normal eye is able to do that, but the other eye, because the inferior rectus muscle is not able to work, it stays looking forward. And so you have the two eyes not reading the same area and you get double vision. All right, now we come to the muscles that actually move the eye. So we talked about them a lot before, but now we're actually going to learn exactly what they are and what they do. So it helps to learn about the four rectus muscles because they're quite straightforward in the way they work. You have the superior, inferior, medial, lateral. So all four axes, they have different rectus muscles. So think of them as lying above and on either side of the eyes. And what they do is when the superior one contracts, it'll elevate the eye. The inferior will depress the eye. The lateral ones will move it to either side. So lateral will move it laterally or abduct it. So that means moving away from the midline, and adduct, the medial rectus will adduct it or move it towards the midline. That's how you have these rectus muscles coordinating movements of the eyes. In terms of innervation, the superior, inferior, and medial rectus are all by the ocular motor nerve, so easy enough to remember. The only exception is the lateral rectus, which is done by the abducens nerves, which makes complete sense because it's the nerve that's going to be causing abduction of the eye and therefore innervating the lateral rectus muscle. So just keep that in mind as well. And then we have two other special muscles, which are the superior and inferior obliques. The inferior oblique is a little bit easier to understand because it's just a muscle that runs obliquely or at an angle and grabs onto the eye and causes it to extort or rotate outwards. Whereas the inferior oblique, so the superior oblique, is a bit more of a special muscle because it also runs obliquely at an angle, but it can cause intorsion of the eye, but it can also cause the eye to be moving downwards when you're looking inwards. So that's a bit of a complicated concept to understand, but I found this really nice video online that I labeled so that it makes a bit more sense. You can see how the superior oblique muscle actually connects to this portion of bone called the trochlea, and then comes back to connect to the back of the eye. So then it's able to pull on the eye and make it intort normally. But then let's say you're looking inwards, so you adduct your eye and you look more medially with the eye. Then when your superior oblique muscle contracts, because of the way that it sort of runs back onto the eye, it actually pulls the eye down in that position. So just keep that in mind, that everything sort of makes sense with the way that it works. So superior rectus, lateral rectus, medial rectus, inferior rectus all do what they sort of describe, but the superior and inferior oblique kind of have opposing actions when you look inwards. Rather than the superior oblique pulling the eye up, actually pulls the eye down, and the inferior oblique does the opposite. So I hope that diagram sort of clears it up, and you can have a look at that in more detail to see exactly how it works. But then the final point I want to cover is, again, innervation. Ocular motor innervates most things except for the lateral rectus and superior oblique. The lateral rectus is by the abducens nerve, which makes sense because that's going to be the one abducting the eye. Superior oblique is by a trochlear nerve, which again kind of makes sense because the trochlea is actually the bony structure the superior oblique is attached or tethered to. So keep that in mind as well, that everything is ocular motor except for superior oblique, which is trochlea, and lateral rectus, which is abducens. And now when it comes to H testing, we actually test these muscles and see if they're intact and working correctly. The way that H testing is work is you get someone to follow your finger and you move your finger in a H. So you go left, or for the patient's left, and then move up and down, and then go back over here and follow the other part of the H. So move up and down. And again, I would be normally following the finger as well. So like that, and like that. So you're really testing the extremes of the vision. And it's a quick method for you to see if those muscles are intact. Three important things to understand is how nerve palsies of the abducens, trochlea, and ocular motor nerves manifest in terms of how the patient would present. If you had an abducens nerve palsy, so that's where your abducens nerve is impacted, then your lateral rectus won't function. You won't be able to abduct the affected eye. All right, so you won't be able to move the affected eye away from the midline and look more laterally. And so if you have a look at the diagram on the right here, at the sort of image over here, you can see how over here, cranial nerve 6, abducens, you can see how at rest, when the person is asked to look straight forward, the affected eye is actually pointing more inwards. And that's because the abducens nerve, which would normally be pulling it on the other side and sort of making it become more midline, is impaired. And so the medial rectus dominates and pulls your eye inwards. And when you ask them to look to the right in this case, because the left eye is affected, or the right eye is affected, because they're unable to look to the extremes, lateral, with the abducens nerve or the lateral rectus, they're still going to be looking straight rather than looking to the right, and they're going to have double vision as a result. But they can look fine if they look to the left because the medial rectus muscle on the right side is not affected. Hope that makes sense. And the trochlear nerve palsy is again only going to impact the superior oblique muscle. And remember, the superior oblique muscle is responsible for causing depression of the eye when the eye is adducted, so pointing inwards. So it'll cause depression of the eye when your eye is adducted of the affected eye. And commonly the words you'll see in an exam is that the person has problem walking downstairs because they're going to have to look down and maybe even a bit more medially. And if they have impaired coordination of that eye to be able to do that, they're going to have double vision when they're walking down the stairs and maybe even trip down the stairs. So that's trochlear nerve palsy, which is this diagram here. You can see that everything looks fine, but then because the patient's right eye is affected, when they try to look to the left, they're going to have some impaired movement because the superior oblique is unable to sort of bring the eye down, and so it sort of points more up than the other eye does. But more specifically, you can test for it by asking the patient to look in and down, and they won't be able to do that with the affected eye, which we'll be able to see on the H test. The ocular motor nerve palsy is a cranial nerve 3 palsy. Again, it innervates everything except for lateral rectus and superior oblique. So think about a situation where only those two muscles are intact. And if only the lateral rectus, which is going to abduct the eye, and the superior oblique are intact, so they're going to bring the eye up, you're going to have a situation where the eye is down and out. So if you have a look, when the person's looking straight, the affected eye is down and out. All right. And finally, we also have this thing of ptosis, where because the ocular motor nerve also innervates one of the eyelid muscles, which we'll come to in a second, it causes the eyelid to droop. And we'll talk about that later on. But all those nerve palsies and the resulting effects of it are summarized in the table below. So take a look at that and see if you're able to reason as to how affecting those nerves affects and causes the presentation as shown here. All right, now we come to eye innervation. So I'm only going to briefly discuss this because you'll have a dedicated lecture on this, and it's not too big of a point to discuss. But when it comes to sensory innervation of the eye, the cornea, ciliary bodies and process, and the iris are innervated by the nasociliary branch of cranial nerve V1, or the ophthalmic branch of the trigeminal nerve. Sympathetics wise, as you know, all sympathetics originate from the intermediate lateral cell column of the spinal cord. They go into this sympathetic trunk, and as with most sympathetics, they hijack and sort of follow arteries. In this case, it's going to follow the internal carotid artery and then form short, long, and nasociliary nerves that are going to innervate the inferior tarsal muscle and the ciliary muscles. And you can have a look at the diagram on the right there, which sort of tries to summarize that. In terms of parasympathetics, you're going to have the cranial nerve nuclei that innervate them, being the Edlinger-Westphal nucleus and the superior salivatory nucleus. Again, you're going to be learning more about what these nuclei are and what they do in a later video. But the Edlinger-Westphal nucleus has a branch which travels with cranial nerve 3, and that's going to then come out the supraorbital fissure with cranial nerve 3, or the ocular motor nerve, and then it's going to have a branch that comes into the ciliary ganglion, synapses there, forms a short ciliary nerve, and in terms of superior salivatory nucleus, it's going to have a branch which is the greater petrosal, which then becomes the Vidian nerve, and then it again synapses at the sphenopalatine ganglion and forms a lacrimal nerve, which is going to innervate the lacrimal gland and induce things like tearing. So that's all that's summarized into one slide. And let me know if you have any questions about that as well. The next one here, though, is very, very important for your anatomy and also for clinical context, because it's a very fair game for the exams as well. So this slide covers how exactly the visual information in the real world hits the retina, travels along the visual pathway, and gets to the visual cortex at the back of our brain, in the occipital area. So the diagram on the left is talking about the 3D sort of reasoning behind everything, but we'll start off with an easier version, which I think is probably this diagram in the middle here. So as you can see, the left part, or this diagram is showing it on a different side, but this is supposed to be the right here, and that's supposed to be the left. All right, so this right part of the visual field, it hits the medial aspect of the retina, also known as the nasal aspect. So you can call this part the nasal and this part the temporal, or medial and lateral, same thing. Hits the medial part of the retina and then travels through the optic nerve. But then at the optic chiasm, all the nerves sort of do a switch over, all the medial ones at least, and then they travel back to the lateral geniculate nucleus and to the visual cortex. Now, the main thing to understand here is that it all crosses and swaps over at the optic chiasm. So this optic nerve on the lateral borders, they stay where they are and go normally, but the medial optic nerve parts, fibers, they cross over up the optic chiasm. And as a result, you have the right side of the visual field ending up on the left visual cortex, and the left side of the visual field ending up at the right visual cortex because of the way they cross over. Now that's sort of talking about the right and left distinction. The next bit though is talking about the superior and inferior distinction. So the superior visual field, the upper quadrants over here and here, end up again at opposite parts. So what happens here is that your left upper quadrant is detected by the medial lower quadrant of the retina. And then because it's medial, it'll cross over at the optic chiasm and end up inferiorly. But notice most importantly here, the superior parts end up inferiorly and the inferior parts end up superiorly here and here. So main message here is it all crosses and swaps over, and that's sort of shown in the diagrams there. Clinical application wise, it's important to understand how different lesions along the optic tracts can cause visual field defects. And there's a whole like summary table here which talks about how if you have a lesion here, here, how it affects your vision and visual field deficits. Probably the most important one, which you'll be seeing or hearing a lot of, is a pituitary tumor. Because the pituitary sits very close to the optic chiasm, there's a tumor of the pituitary gland that causes it to grow and swell and become big. It'll impinge on the optic chiasm below, hit those medial fibers, the medial retinal fibers, and therefore you're going to lose vision that comes from the lateral or temporal visual fields and would go through there. So you're going to have bitemporal, or I wouldn't say bilateral, but bitemporal is a better way of putting it, bitemporal hemianopia. So you're going to have a loss of a hemisphere or half of your vision on the temporal aspects of both your visual fields. To see if you can understand why that's the case and keep that in mind. That's probably the most important thing to keep in mind from the slide set. So that was the visual pathway and lesions of the visual pathway. And again, let me know if you have any questions about that. But now we come to the pupillary reflexes. Again, another very important topic clinically, because you'll be asked to do this in clinical skills when you're doing cranial nerve testing, but also be able to talk about different pathologies that might cause the reflexes to present in different ways. The most important thing to understand here is that the pupillary reflex is not just testing the optic nerve. It's testing the optic nerve, but also the efferent part, which is the ocular motor nerve. So when someone asks you what is the pupillary reflex composed of, don't just give the afferent component, which is the optic nerve, but also the efferent component, which is cranial nerve 3. So what happens is when you shine the light into someone's eye, into one of their eyes, then the signal, the afferent signal, is conveyed via the optic nerve, cranial nerve 2. It then goes through to the pretectal nuclei, but most importantly, it stimulates the Edinger-Westphal nuclei on both sides bilaterally. So notice how we shone light onto one eye, but ended up stimulating bilateral cranial nerve nuclei. As a result of that, you're going to stimulate both sides bilaterally, the ocular motor nerves, and specifically the ocular motor nerve, so cranial nerve 3, is going to cause the pupils to constrict bilaterally. So that's how you get the effect of shining light into one eye, but causing both eyes to constrict, which is really interesting to have a look at. So see if you can maybe go home, get your phone torches and shine light into someone's eye, covering up the other eye like that, and shine light into one eye, and observing how both eyes constrict when you shine light into only one eye. Now, there's 3 tests that we normally think of here. The first one is a direct reflex, where you shine the light into one eye and the same pupil constricts, which makes sense because your eye is responding to a brighter stimuli by constricting the pupil and therefore limiting damage to the retina. The consensual reflex is where the opposite eye consents and also sort of constricts. So you shine light into the left eye, for example, you're still covering the right eye so that the right eye is not receiving any light, but it still constricts, right? So you have both eyes constricting, even though you're only shining light into the one eye. The swinging light test is where you actually shine light into both eyes by moving the light from side to side between each eye. So you're sort of going on the left eye, then the right eye, and the left eye. Now, normally, because you're shining light into one eye at any point, they both should constrict and remain constricted because of the fact that shining light into one eye will cause bilateral constriction. However, if that doesn't happen and you actually end up having an eye dilating, that indicates that the optic nerve isn't functioning and it's not giving the afferent signal, which is going to cause both eyes to constrict. And therefore, you have what's called RAPD, or relative afferent pupillary defect, which points to a unilateral retinal or optic nerve issue. And so that's the clinical context behind it as well. Now, if you're doing cranial nerve testing and you're looking at pupillary reflexes and everything is fine in terms of the pupils being equal on both sides and the reactive to light, you can sort of summarize that as PERL, P-E-R-L, or pupils equal and reactive to light. And there again on the right is a bit of a diagram summarizing everything that we've covered so far. Next up, we have the eyelid and its anatomy. It's not too big of a point to cover here. I'm just going to talk about some of the muscles and the innervation of the muscles and focusing more on the clinical context so it's more relevant to you as well. So the first muscle is the orbicularis oculi muscle, which and the palpebral part of that is going to form the upper part of the muscles that are around the eyelid. And it's innervated by cranial nerve 7, or the facial nerve. And the application of this is in Bell's palsy, where you have a facial nerve issue. You're going to have an inability to be able to tightly shut your eyes because the cranial nerve 7, that's innervating the orbicularis oculi, is affected. Next up, we have levator palpebrae superioris, which is going to control the upper eyelid, and that's innervated by cranial nerve 3, or the ocular motor nerve. And again, we've talked about this before, but in ocular motor nerve palsy, besides all the extraocular eye muscles effect, so the fact that you're going to have a down and out eye, you're also going to have ptosis because the upper eyelid is unable to contract and be able to pull back and open the eye completely. And then the final thing to cover is a superior tarsal muscle, which is innervated by the sympathetic nerve system, the T1 fiber specifically, or the fibers that come from the T1 level, from the IMLCC there. And that's important clinically because of Horner's syndrome, where you have impaired sympathetic nervous system signals to that particular area. For example, the reason might be that you have what's called a Pancoast tumor, or an apical lung tumor, that's impinging on the sympathetic nerves in that area that's coming out of the spinal cord. And therefore, your eyes have impaired sympathetic nervous system stimulation. And so they're again going to have partial ptosis because the superior tarsal muscle is unable to contract and open up the eyes. It's going to be partial because there's still the levator palpebrae superioris muscle, which is going to be intact. We're still going to have some ptosis there. And also, if you lose the sympathetic nervous system component, then your parasympathetic one will dominate, and you're going to have things like red watery eyes because of increased secretions caused by parasympathetic nervous system. We'll learn about Horner syndrome as well. Now we come to the eyeball itself, which is covered in your physiology lectures. I'm going to very briefly talk about it here. There are three main layers of the eyeball, which we're going to be covering: the fibrous outermost component, the vascular component, and then finally the innermost component, which is sort of the more neural component that contains the retina, macula, and optic disc. In terms of the fibrous outermost component, we have the cornea and sclera. The cornea is a transparent structure. It's relatively avascular, and it's going to be the primary refractory medium that's going to be responsible for bending light when it reaches the retina. The sclera, on the other hand, is an opaque white structure, which is important clinically because if you remember, we have a look at the sclera quite a bit in, for example, the GI exam to look for jaundice or to look for pallor and anemia. Then we have the vascular part of the eyeball, which is composed of the choroid, the ciliary body and process, as well as the iris and pupil. So the iris is this structure which is composed of two muscles, the sphincter pupillae and dilator pupillae. Sphincter is going to cause constriction, dilator is going to cause dilation when it's activated. So think about what contexts you would have them being activated in. So if you want to dilate the eye, think fight or flight, think SNS, because you want to dilate the eye and respond, for example, to dangerous stimuli, fight or flight, sympathetic nervous system. And these are radial muscles that, when contracted, actually pull the pupil open wider. Sphincter pupillae, when it's contracted, it actually is got circular muscle fibers that when they contract, cause the pupil to shrink. And think of that as more as a rest and digest, relaxed reason as to why you have the parasympathetic nervous system being activated there. The ciliary body is a structure composed of ciliary muscles and ciliary process. The muscle is going to be responsible for adjusting the focus of the lens. When it contracts, it's actually very interesting how it works, but when it contracts, it actually causes the ciliary, the suspensory ligaments, to relax, and therefore the lens to bulge, and therefore you'll be able to look at nearer objects because it causes the rays to be more refracted, essentially. Whereas the ciliary process is going to be responsible for secreting aqueous humor, and the choroid is going to form the rich blood supply of the eye. The innermost structure is the retina, the macula, and the optic disc. The retina is going to contain rods and cones. Rods are more for low light vision, cones are more for bright light and color. The macula is the portion of the eye which is going to have the most acute and clear vision because it's composed of 100% cones and no rods. The optic disc, however, is the blind spot of the eye because it's where your cranial nerve 3 plugs into the eye, and so will contain none of those rods and cones, and you'll have a blind spot there, which you can test for with the cranial nerve testing and blind spot testing. Then we have clinical context of glaucoma. So this is talking about when you have impaired drainage of the aqueous humor. So if you remember, we said the aqueous humor was produced by the ciliary process, ciliary body, and what happens with glaucoma is the drainage of the aqueous humor becomes blocked, but secretion from the ciliary process continues, the ciliary body continues. And so the aqueous humor builds up and causes pressure to rise, and that's going to push on the lens posteriorly. So as you can see, if that pressure were to rise, it'll push on the lens posteriorly, causing, amongst other things, visual problems. It'll also compress the chamber behind it, which is the vitreous chamber, and pressure built up in the vitreous chamber, which is the eye itself, is going to then damage the optic nerve and cause an increased cup, which can cause things like ischemia and cause permanent blindness and damage. There's two types to know about. One is open angle, where you have, it's the most common type, where you have the blocked trabecular meshwork. And so you have low flow and absorption through the trabecular meshwork over here before it can enter Schlem's canal. And the closed angle is, as you can see here, where there's an obstruction here with the iris and the cornea. And so that causes much more pressure buildup and is therefore a bit more of a medical emergency. And you'll learn about that as well later on. And then finally, we have vision impairment, which is the final slide here. I'm talking about myopia or short-sightedness, and hyperopia, presbyopia, astigmatism. So myopia is short-sightedness. It's where the image converges before the retina. So you can see that over here in the middle image. The image is sort of getting converged and forming in front of the retina. And that's because the axial length or the diameter of the eye horizontally is too long, and therefore the image is falling short of the retina, or there's too much refractive power and the rays are being refracted and converged too early on. So you can correct that with a concave lens as shown there. Hyperopia is where you have far-sighted vision, and that's where the image converges after the retina, so you're able to see things that are far away fine, but not things that are close up. And that's caused by the axial length being short, or with too little refractive power, and you correct that with a convex lens. Important to know here is that age-related farsightedness is often termed presbyopia. And then finally, astigmatism is just sort of the loss of the normal spherical curvature, which is causing a visual field defect. And so the light rays do not converge normally, and you end up with a blurry and distorted image. And that's corrected by lenses that are sort of a combination of both. So that's it for the anatomy and physiology of the eye. I hope that all made sense, and we'll see you in the next one.